Before we start, I'd like to invite Dr. Vici to be on the panel. Dr. Azad will join us shortly. So on behalf of the SAO and the Indian ROP Society, I'd like to welcome all of you on this South Asian Ophthalmology Symposium on Retinopathy of Prematurity and Newer Developments. We have a string of specialists coming from different countries. We have Dr. Domenico Lepore from Italy, and we have Dr. Vici Wu from Taiwan. It'll be my privilege to start this off. नहीं slides ये पहला slide नहीं है. Okay, so very good morning again, and welcome to the SAO Symposium on Retinopathy of Prematurity. I have no financial disclosures and no conflict of interest. So I'm talking about imaging and newer imaging techniques in ROP, and I think this is so well elaborated in the new ICROP classification, where we started looking at vascular segmentation and and deeper ways of looking at the vessel profile. Let's take, for example, aggressive ROP, where one of the reasons we realized that this disease is so different from aggressive posterior ROP was, let's say, angiography, where we were looking at loops of capillary non-perfusion happening even anteriorly. And then the newer things in the ICROP3 classification, like how to assess regression and reactivation, are again a feature of how we were able to better define these images as we are looking at ROP. Reactivation, for example, can be a vascular reactivation or a ridge reactivation, and even the location of the reactivation has been defined purely based on what's happening on an image. Plus disease, I think all of us have struggled with it for decades now, and the fact that two or more experts may not even agree, and this has been very elaborated in several studies, and therefore imaging again has come to our help. The P-score has recently been released, and now I think we have a very objective score where we can put this up in our clinics, and from P1 to P9, it's a great way of two ROP experts communicating, especially when referrals happen. Let's talk a few about the newer imaging devices. So in our own program, in the KidROP program, we have a telemedicine program where we started to use the RedCam shuttle. It's wonderful. It gives us great images, but the program was not scalable because of the cost of the camera. So this was an Indian camera that was invented, and we have subsequently, I believe it has an FDA and a CA approval, and now has installations everywhere. The newer version of the Forest Neo has the angiography on it as well, and I think in this era of anti-VEGF and anti-VEGF therapy, angiography plays a very important role. There are also even lower, more affordable camera devices where you put in just a smartphone, what they call a smartphone assisted camera, where you put in a regular 20 diopter lens, or a 28 if you will, and connect it with an app that the developers have created. And yes, it's not as wide field and it doesn't have the ecosystem of a telemedicine program, but certainly very good for photo documentation. So may not be telemedicine, but great for photo documentation. Yes, so angiography, I'd like to spend a little time on looking at, oral angiography is being also performed in India. And here's an example. I think all of us see these cases now, aggressive ROP, which is what we call in India zone half, which is popularly actually should be called posterior zone 1. And it does very well, and that's when you begin to think that the vessels are fine and completely mature. But then when you do the angiogram, now this is a baby who's already almost 4.5 kilograms, and you have a large area, and again this is defined based on an image of 2 disc diameters or more of persistent avascular